Welcome, everybody. We will start the presentation as some people are starting to still roll in. I'd like to thank everyone for joining us tonight for our last Brain Matters webinar for the series, Dementia, the Basics with Dr. Michael Borrie. My name is Dina Boone, Public Education Coordinator with the Alzheimer's Society London and Middlesex. I will be the MC and moderator for tonight's webinar. Susan Oster, Dementia Friendly Communities, will be our technical support person today. At the Alzheimer's Society, our role is not only to provide programs and services to people who are going through the journey of dementia, but also to provide dementia education and to advocate for those living with cognitive disabilities. Today's presentation has been generously supported by RBC Wealth Management Dominion Securities. To bring video greetings from RBC Dominion Securities, here is Jessica Thomas, Portfolio Manager at RBC and a board member at the Alzheimer's Society.
Thank you for the opportunity to participate in the Alzheimer's Society Brain Matters webinar series tonight. My name is Jessica Thomas. I'm a portfolio manager at RBC Dominion Securities and also a proud board member for the Alzheimer's Society. Our team is really looking forward to being the presenting sponsor for tonight's presentation featuring Dr. Borrie. It's going to be wonderful to learn more about the basics of dementia, the risk factors, and overall brain health. And of course, understand some of the really important research that's happening in this area. At RBC Wealth Management, we certainly appreciate the value of preparation and planning for the future, especially when a diagnosis of dementia comes into the picture. We are dealing with clients and families each day that have experienced this disease, and the more we can learn, the better that we can help our clients and serve this community. On behalf of RBC Wealth Management, I'd like to welcome you to tonight's event. Hope you find it extremely engaging, informative, and most of all, hopeful. Thank you.
Thank you, Jessica. Before we begin, I have a little business to go over relating to your webinar experience this evening. Please note that your cameras are off and microphones are muted for the webinar. This event is being recorded and will be available in the future on our website for viewing. At the end of the presentation, we will have approximately 15 minutes for a moderated question and answer period. We will do our best to answer as many questions as possible. During the presentation, if you think of any questions for Dr. Borrie, please add them to the question and answer box located at the bottom of your screen as you see here, marked Q&A. If you would like to submit an anonymous question, please click the Send Anonymously box before clicking the Send button. All questions which were submitted prior to the webinar have been shared with Dr. Borrie, and he will address these questions during his presentation. For this webinar, we have also enabled a new feature called Upvote. This allows people to see all questions being asked and to move the most popular questions to the top of the list. If you see a similar question listed by someone else, you can simply vote on the question by clicking on the thumbs up icon underneath the question as seen here on the screen. Once the icon is clicked, the question will move to the top of the list. Should you be having any technical concerns during the presentation, please type in the chat box and Susan will be happy to help you. You may need to move your cursor around to see the Zoom controls and icons. You can submit your comments in the chat box to all attendees and panelists, viewable by everyone. Panelists only includes ourselves. There's a little drop-down box menu as well. Please note that the opinions expressed by all participants are their own and are not necessarily representative of the Alzheimer's Society, London and Middlesex. Since everyone's situation is unique, the information being provided in this presentation is for educational purposes only and not advice for your situation. Should you have specific questions about your situation, please contact your doctor for advice. We have the pleasure of welcoming Dr. Michael Borrie and over 200 people who registered for this event, both locally and across the province. This reflects not only the expertise of Dr. Borrie, but also the thirst for knowledge of our aging population. Dr. Borrie is a geriatrician at Parkwood Institute, St. Joseph's Healthcare, London, and a professor in the Department of Medicine, Division of Geriatric Medicine at Western University. He is the medical director for the Aging Brain and Memory Clinic, an investigator with the Cognitive Clinical Research Group, and past president of the Consortium for Canadian Centers for Clinical Cognitive Research. And now, please welcome Dr. Borrie.
Good evening. Thank you for joining us for this talk on Dementia, the Basics. I think by the end of the presentation, you will realize that it's more than a basic issue. It's actually a very complex condition because the brain is the most complex organ in our body. In terms of my acknowledgements, I have had research support through the organizations listed there. I've been a consultant and done continuing medical education programming for the pharmaceutical companies listed and clinical trials funding from this, and that's over a period of about 25 years. So the objectives that we want to cover is to look at the spectrum of cognitive decline and the common underlying diseases, discuss what you might expect when you visit a family physician, learn about the risk factors for dementia and how we can actually reduce that risk and keep our brains healthy, give an update on some aspects of clinical trials research, in fact, the most recent announcements in the last week, and learn about the opportunities to participate in research. This began in 1906, Alois Alzheimer observed a 52-year-old woman who had progressive neurologic decline, beginning with memory impairment, had paranoia, became immobile, and died after 4 years. And at autopsy, he found two phenomena which were new, plaques and tangles, which were really quite prevalent throughout the brain. And he described this as Alzheimer's disease. Subsequently, or became known Alzheimer's disease after him, and other terms that have been used are senile dementia Alzheimer's type, SDAT, or dementia probable Alzheimer's disease. Now, these terms all mean the same thing, they're synonymous. This is a condition that's important because of the numbers that are going to be involved. So well over 1 million in Canada by 2038, most living in the community. You also recognize that this is a disease more common with old age, but it's not caused by old age. And it has an economic burden estimated there in 2008 at $15 billion, direct and indirect, and then by 2038, $153 billion. So this is something that we're going to have to pay a lot of attention to. This describes the spectrum of cognitive decline that we have developed and used in the Aging Brain and Memory Clinic. On the far left, you can see people that we might regard as supernormal. They don't come to the clinic. They are people in their 80s who score the same as 20-year-olds on memory tests. People with age consistent loss who are regarded as normal. These are people in their 50s, 60s, 70s, 80s who may occasionally have memory difficulties, some word finding difficulties. They're not concerned about their memory, and they score well on in the normal range on a test. And we'll describe this test later on. The MoCA is the most common one used in Canada, is the most currency at present. And then people with subjective cognitive decline are people who say that their memory has changed after the last 2 or 3 years, may be concerned about it, concerned enough to come and have it assessed or be seen by a family physician. But when tested, they score in the normal range, 26 or better on the MoCA. And then people with mild cognitive impairment not only have change over the last few years, they also have concern, and they have impairment on that MoCA, less than 26 out of 30, but the instrumental activities of daily living are intact. And people with dementia are people who not only have change and measured on the MoCA, but they also have their instrumental activities of daily living are significantly affected. And that's one or more of the instrumental activities of daily living. And we'll talk about instrumental activities a little later. Prodromal dementia is that interval between mild cognitive impairment and dementia, where one is anticipating progression to dementia. Mild dementia, moderate, severe, and advanced dementia are characterized using a different memory score, the standardized mini-mental state exam, also scored out of 30. You can see the ranges below those descriptions there. This diagram depicts a course typically over a number of years. This is showing 9 years. It could be longer or less. And out to the left, mild cognitive impairment for several years. And then on the vertical scale, out of 30, a mini-mental state exam. And you can see there's a decline, and there is an inflection point where the decline becomes steeper. And this is often the point where families say there really is something going on. This is not just getting a bit forgetful in old age. This is really serious. And they'll get a diagnosis. There may subsequently be functional decline, behavioral problems, and even nursing home placement. There are risk factors, some of which can be changed and others which cannot be. Age, the ApoE4 gene cannot be changed. Obviously, you get 2 copies of ApoE4, 1 from each parent, and it comes in 3 variants, if you like, ApoE2, ApoE3, and ApoE4. And if you've got 1 or 2 copies of ApoE4, you're at increased risk of developing Alzheimer's disease. So this is the most obvious genetic risk. It doesn't guarantee you'll get Alzheimer's disease, but increase the risk. In the Canadian population today, 15% have 1 copy of ApoE4, and 3% would have 2 copies. In our clinic, the people that are referred to already have memory concerns, 50% have 1 or 2 copies of ApoE4. And that ties into the family history because these people often will have a family history of people developing dementia in their 70s or 80s. The things that we can prevent are listed there, and we're going to talk more about that. You've had a chance to have a look at them. And if you could actually eliminate some of these risk factors, this is from Livingston's paper, the second version in 2020. The reference is there if you wish to read the whole paper. But this is really an estimate of the percentage reduction in dementia prevalence. That's the number of people in the population at any one time that actually have the condition. That's the reduction in the prevalence that would occur if you could address these risk factors. So showing that about 40% of the prevalence could be reduced if we could eliminate those risk factors, still 60% unexplained by reversible factors. This is another way of looking at risk factors. And you can see there on the left-hand side, the age increasing in 5-year increments. And if we just look at age alone, the risk is increasing from 1% at 60 to 64% at 90. But then if you add in 1 or more of those risk factors shown on the previous slide, you can see that there's a doubling. So there's a doubling every 5 years just by age, but there's also a doubling if you add another risk factor. So age plus 2 risk factors at 80, 2 risk factors increases the probability of dementia, or certainly cognitive impairment, to about 64%. A diagnosis of mild cognitive impairment due to Alzheimer's disease is something that is detected by a person and also family members, seeing that there is a decline in a cognitive area. The decline might be in memory or planning, what we call executive function or attention or language, and spatial skills, spatial orientation. And most commonly in Alzheimer's disease, or people with mild cognitive impairment who are going to progress to Alzheimer's disease, it's the short-term memory that is affected, not long-term memory. There is a preservation of instrumental activities of daily living. So by definition, if a person's activities of daily living are preserved, so their ability to work, cook, do finances, technology, housework, yard work, those things, if they can do all of those things more or less as they used to, they may take a bit more time or be less efficient, maybe may make more errors, but if they can do those, they don't have dementia. They still meet the criteria of mild cognitive impairment, or this has to be confirmed by a family member or friend, and someone who obviously doesn't have cognitive impairment, so they can make a reasonable judgment about this. And then it's helpful to have additional evidence objectively using a MoCA test, and if it's done repeatedly over time, that is even more helpful. A single MoCA test does not make a diagnosis of dementia. Sometimes people don't perform the first time because they are anxious, and subsequently, when you do the test again, they do better. Dementia, on the other hand, you've still got this insidious progression over months or years, certainly not hours or days. That really talks, it's things that happen in hours or days is usually delirium, which is the acute confusional state we see in people after hospitalization. But this is worsening over a longer period of time, and there's this worsening, and the deficits again is particularly learning new information, what happened yesterday, what happened today, what they were just told a few moments ago, when it gets really severe. And as well, other cognitive domains, language, the visuospatial, executive function, and then there has to be absence of other neurologic conditions like strokes and the absence of any psychiatric illness. Now, there can also be changes in mood as well, and these symptoms, there can be even changes in behavior along with memory, and these things should be taken seriously, reported to a family physician, who would then take a history from a family member separate from the person with the memory concern, and then do some sort of an assessment like the Montreal Cognitive Assessment, which is shown here. This is the top portion of the test. We start off, usually we would start off with the animals, which are easier, naming the animals, drawing a clock and putting the time in at the 11:10, the cube copy, and then a modified trails B shown there, and then the registration of the 5 words, which is the most sensitive part of the test. They have to, given those 5 words, they have to repeat them back, give them again, and then asked to remember them, and then they come back to the second test. Now, there are different versions of this test, so you can give different versions on different occasions. There's tests of attention and language is shown there, and then you come back, and abstraction, you come back to the delayed recall. What were the 5 words? They may not be able to remember any of the words. They may be able to remember some with what's called category queuing or multiple choice queuing. So it's, you give one of the words out of 3 to get a multiple choice queue, and then the points on orientation to place and time, and this is scored out of 30. Blood tests are often done to rule out reversible metabolic causes of memory problems. These are uncommon and usually have been addressed by a family physician. We do brain imaging. In our own clinic, we prefer a magnetic resonant imaging scan, an MRI scan. It's a magnetic scan as opposed to the X-ray scan, a CAT scan. And those are the indications for compelling reasons for having a scan. But most of the people that we will see will have had a scan. Sometimes, very occasionally, they may be quite claustrophobic, and then we may favor a CAT scan, which is shorter and more open than the MRI scan. Now, we're going to talk about the different types of dementia, and we have to think of types of dementia or dementia as a broad category. So if we talk of, say, motor vehicles, a car would be a form of transportation. And then if we look at the types of cars that are available, you have different brands. And you can think of the different types of dementia as being different brands of cars, if you like, as a simpler way of thinking about it. So this shows the pathological change that Alzheimer's saw on the right side of the screen. So those normal neurons are now changed, and between the neurons are these amyloid plaques. The amyloid plaques, he didn't know it was amyloid at the time, but these were the plaques he was seeing, and this is an aggregation, collection of sticky protein, amyloid protein, which is abnormally, it's a normal protein, but has become misfolded and forms these plaques in the brain. We all have amyloid in our brains as a normal protein, but when it becomes misfolded, it forms these abnormal collections in the brain. And then there is these tangles within the nerve cells, those purple nerve cells, disrupting the nerve cells. And when they die, that's when the memory impairment starts to decline. Vascular dementia or multi-infarct dementia is an older term as due to small strokes, and we can see these on a head CT scan. And these people don't have other causes of cognitive impairment, such as delirium, which I mentioned earlier. And if we do an MRI scan, this is just one slice of an MRI scan, and you can see the arrows showing the areas of stroke surrounded by white matter changes. And you can also see some at the lower portion around the ventricles, the paired ventricles. You can see more extensive white matter change in the brain. So these are some of the vascular changes we can see on an MRI, and we can see this more clearly on an MRI than a head CT scan. Frontotemporal dementia, there are 7 different variants, and 2 that I'm going to mention here are the behavioral variant and the language variant. So the behavioral variant, also called Pick's disease, disinhibited behavior, changes in personality and apathy, and it can be measured using a frontotemporal inventory. This is a questionnaire with 24 questions. The family member will answer these questions separate with the specialist or maybe the family physician to try and determine what the score is, to see if this might be evidence to favor this diagnosis. With the language variants, the so-called primary progressive aphasias, there are 2 forms: the progressive non-fluent aphasia. These present with effortful, hesitant speech and word-finding difficulties, and then the semantic variant, where there's fluent speech but difficulty comprehending words and difficulty understanding the meaning of words. Lewy body dementia is another type of dementia, if you like, under that umbrella of dementia. Visual hallucinations, Parkinsonism, fluctuations in the levels of consciousness, and then a sensitivity to some of the typical and atypical antipsychotic drugs. Restless legs may be part of that as well. And it can be often difficult to diagnose because it can be mixed in with other types of dementia, like Alzheimer's disease or with Parkinson's disease. So you can see a combination of these things as well. Make things more complicated, vascular dementia and Alzheimer's disease can overlap, and people can have features of strokes. They may also have features of Alzheimer's disease, so-called mixed dementia. And with that, preventing strokes is important because this preserves brain function. And these are the things that you can do at home, making sure that the blood pressure standing is in that sort of range. 130/80 would be a reasonable blood pressure to have. For home blood pressure recordings, diabetes is monitored at home. There are non-drug approaches to try and address cholesterol as well as medications. And smoking should be avoided, or efforts to stop made with the assistance of a family physician often. Atrial fibrillation, there are medications, anticoagulant medications, so-called blood thinners, and then aspirin, which reduces the platelet stickiness in the blood to reduce strokes. Now, this is a condition which is more recently described in 2019, the limbic age-related encephalopathy, and it's from this protein, this TDP43 protein. That was first discovered in 2006, the protein was, and it was a signature protein of ALS or Lou Gehrig's disease. It's also the protein most commonly seen in frontotemporal lobe degeneration, the FTD type of dementia. But we also now recognize that many elderly people in their 85 and over, 25% of those have enough TDP43 to actually affect memory and thinking. So 17% of those people who have their memory often in their late 80s and 90s, where memory is really is affected and they're really quite profoundly forgetful, but often their personality is not affected. And so they're sort of their personality is preserved. There's not necessarily the behavioral changes, but it mimics Alzheimer's disease in that there's the memory loss and there may be problems with reasoning and thinking. On imaging or autopsy, there's severe shrinkage of the hippocampi, and the hippocampi are what we would call the memory departments within the temporal lobe of the brain. It's not clear when this actually starts, and some of these people that have been diagnosed with Alzheimer's disease may have this condition that we are now calling late. And so this is going to be important for clinical trials in Alzheimer's disease, and some of the information we're going to share a bit later in this talk is that it's going to be important to be able to differentiate between Alzheimer's disease and late. You don't want to be treating people with late with treatments specifically designed for Alzheimer's disease because they clearly won't be able to work. So with a family doctor, the things that one might anticipate is management of the vascular risk factors listed there, encouraging reduction of alcohol or drugs that might affect cognition. And this would include over-the-counter compounds like Gravol that some people take as a sleep aid. This has a very strong anticholinergic action. That's the term we use for it. And so Gravol should not be taken on a regular basis for sleep. And treat depressive symptoms using non-drug and drug approaches. And then there are other things listed there that the family physician may talk about and may even prescribe physical activity. And the specialist would often have a lot of those things would be covered in a specialist clinic as well. 6 non-drug strategies to reduce risk are listed there, and I'm going to go through some of the evidence for some of these to try and give you some idea. We certainly know from the paper with Erickson that there's brain imaging evidence using MRI showing that physical activity can be associated with greater gray matter in the prefrontal cortex and hippocampus. This is important parts of brain function. A number of randomized controlled trials where people have been people who have dementia randomly assigned to exercise versus a control activity, showing that this may be quite beneficial and may reduce the progression or slow the progression of dementia. And if anyone needs motivation for exercise, I would encourage you to look at this presentation by Dr. Michael Evans. If you just Google 23.5 hours, and this is a very good whiteboard presentation on the evidence around exercise. So there's some additional study on longitudinal studies looking at physical activity in the prevention of Alzheimer's disease, showing that there is a reduced risk of progressing to dementia. The diet is important, and this is a representation of the Mediterranean style diet, and you'll notice that we've removed the bottle of wine. It was never an excuse to drink red wine, although some people thought it might be. This really needs to look at whole grains, fruit and vegetables, some dairy, certainly fish, the omega-3 fatty acid from fish is important for the brain, particularly from, say, salmon and tuna, sardines, herring, those sort of fish. And really using meat uncommonly, and certainly sweets as a treat. And then there is evidence on this, observational studies from the Hardman paper here, looking at some of the evidence supporting the Mediterranean-style diet to actually slow the rate of cognitive decline. This is an observational study over about 12 years in New York from 2009. And this is people who are grouped high physical activity and high diet score on a Mediterranean-style diet compared to the lowest group, low physical activity, low diet scores. And you can see the difference in rate of progression of dementia. So obviously these things don't stop the dementia, but they slow the progression. And so you can see there that there is some evidence that it has an effect. A more compelling study is the randomized study from Finland, the so-called FINGER study, a 2-year study with over 1,200 participants, an intervention group with those 4 interventions there and close monitoring, and a control group who got health advice, and showing that there was improved cognition and reduced risk of cognitive decline for these people. So these were people at risk of cognitive impairment. They were near normal, but were at high risk of progressing to dementia. And there's emerging evidence for these other situations. I'm going to say a little bit about socialization. Certainly sleep is very important, and certainly addressing hearing impairment is important. And this comes data from the just last year, and it was published really quickly early on in June with the COVID crisis, and showing that this study in the Netherlands, that they were able to have residents receive a visitor, and this is during phase 1 of COVID. And they found that the experience was very positive. It had a positive impact on their well-being, and that it was good compliance with the guidelines for doing it. And they didn't have any new COVID infections during that time period, the observation. So this is one of these rapid publications that came out, and it's something that probably we could have learned from as we conducted ourselves in Canada with respect to long-term care. Now, this is going back now, just looking at, so if we think, to summarize in terms of prevention, if we're looking at trying to prevent, we have to look at all of these different domains: increasing brain function and cognitive reserve, reducing brain inflammation, reducing brain damage. And you can see these overlapping strategies. And it's not just going to be a single thing that's going to make a difference, but certainly key to all of this is going to be exercise, and certainly diet is going to be important. Now I'm going to turn now to some of the drug therapies. This is a diagram on the x-axis across the bottom in years, progression of Alzheimer's disease, that reverse sigmoid curve, that sort of steep portion that we know from observational studies. On the vertical axis, we've got the mini-mental state as a measure of cognition. We've got the area called mild cognitive impairment up to the left, progressing to dementia. And then you can see, so that the yellow curve shows the natural course of the disease. The blue curve shows what the response might be to a symptomatic treatment, which have been approved. So we have 4 drugs for symptomatic treatment, and I'll show them in the next slide. But you can see there's a modest improvement if a person does respond, and then there'll be a progressive decline in a parallel fashion to the way a person might progress with the natural disease course. Disease-modifying therapies is where a lot of the research is going to be talking about. So this latter part of the talk, I'm going to talk about disease modification. And if we take that point where the blue line and red line are intersecting off to the left there, if we imagined 1,000 people or 2,000 people in a randomized controlled trial, and the people in the placebo arm happened on average to follow the blue arm, and the people in the red arm, orange arm, was to be in the treatment arm, the end point where they meet that green vertical bar, the people in the disease-modifying arm would clearly be doing better than the group who are on the placebo. That's the ideal scenario that we would like from a clinical trial. So far, none of the clinical trials have had anything that looks like that. That's what we're striving for, is these different disease-modifying treatments. So the current symptomatic treatments, you're probably familiar with the names, donepezil, rivastigmine, galantamine, and their drug company names there in the brackets. And for mild to moderate Alzheimer's disease, can be extended into severe disease, modest effects, and then moderate to severe Alzheimer's disease. There's one paper for memantine, and also modest effects. I certainly don't want to overstate those effects. And memantine is not covered by the ODB. It's about $2.40 a day. Now, this slide really is just to sort of highlight the complexity of Alzheimer's disease. And these are a listing by Dr. Sakin of all of the different biological pathways by which we could actually try to seek treatments for dementia, different types of dementia. And you can see up to the left, amyloid hypothesis and the tau hypothesis have been the predominant theories, and where a lot of the research has been done. But you can see the potential that there's a lot of other areas where there is also potentially promising research to be conducted. And it also speaks to the complexity of this disease. This also talks, this slide now is showing the 2020 Alzheimer drug development pipeline. Across, you can see that there are three circles. In the outer circles, there's phase 1 trials, and the next phase 2 trials, and in the center circle, phase 3 trials. And they've divided it by disease modifying or biological treatments. This would be intravenous antibody to amyloid, or intravenous antibody to tau, or some other intravenous treatment or vaccine, for instance. And then there are disease-modifying small molecules, which is a different class of drug. And then on the left-hand side, there are symptom-reducing small molecules. And you can see, you can go to that reference if you want to study it further. It's a detailed paper, but this has really just come from clinicaltrials.gov, which you could go on, but this is it all in one place in a nice diagram. And if you summarize this, you can see that there are a lot of drugs in clinical trials around the world, and often when they're done a trial, there'll be several countries involved with clinical trials, a certain number of participants from each country participating in that trial. And you can see, compared to 2019, that there are now this year more agents targeting other pathways other than amyloid and tau, and those other pathways are listed below. So coming back to Alzheimer's disease and where the amyloid hypothesis has been, this is the diagram that we spoke of earlier with the plaques and tangles, and this is another representation of this. So across the bottom, you can see cognitively normal across in time to mild cognitive impairment to dementia, and on the vertical axis, abnormality in various things that are being mentioned, measured. And we've got A-beta amyloid, which A-beta is short for the amyloid protein. So we're seeing this abnormal amyloid protein being deposited in the brain over a period of 15 or more years. The next phenomenon is the tau-mediated neuronal injury. So the tau proteins, the tau tangles, causing the nerve cells to be killed. This causes changes in brain structure, the atrophy that we can measure on the MRI scan over time, decline in memory that we measure in the clinic, and the clinical function declining that family members are observing along with the impaired memory. Now, we can measure amyloid in the brain using an amyloid PET scanner, positron emission tomography scan, and the scan on the left is a negative scan. The one on the right is someone who's got a lot of that amyloid protein accumulating in the brain. And where a lot of the strategies have been targeting is to try and remove the amyloid from the brain. And so Aducanumab or Aduhelm, which is the drug that was given approval by the FDA for advancement last week. You can see this is from the phase 1 trial, and this illustrates the dose effect of increasing the dose of the aducanumab. So in the top frames, you've got paired images at baseline, and the one on the left and the one on the right is at 1 year. And so in the placebo, there may be some increase in amyloid. Below that is 3 milligrams per kilogram, below that 6 milligrams per kilogram, and the highest dose that they tested, 10 milligrams per kilogram. And you can see how at 1 year it's removed amyloid from the brain. And you'd like to know that if it's removing amyloid from the brain, this would improve cognition. And we haven't seen that in a compelling manner at this, but we can show that the amyloid can be removed from the brain. And this is the so-called surrogate that the FDA used for the approval. They're saying, well, it's doing something that we know is causing Alzheimer's disease, and so removing it will use this surrogate as of the PET scan as the way forward, as the potential promise that this might be helpful and with the disease. They are asking Biogen to do another trial because one of their trials was a positive trial, but the other one at the lower dose was a negative trial. So there will be another trial, and we'll see what comes from that. So this is the approval from the FDA announcement, and they used that a drug for a serious or life-threatening illness, or certainly Alzheimer's disease provides a meaningful therapeutic advantage, can be based on the effect of a surrogate, that's the PET scan, and then they got another trial to be done. And if that trial fails, they may initiate proceedings to withdraw the approval. There is a warning that aducanumab may cause amyloid-related imaging abnormalities or ARIA, and this is a temporary swelling in the area of the brain, and it may or may not have symptoms. The most common side effects from there. The cost is certainly concerning, $58,000 US, where it's in the States where it's been approved. And then there are additional costs, a PET scan, MRI scans, the delivery of the drug, because it is intravenous, it has to be given. And there may be other costs if there are any side effects of monitoring that person. So the implications this morning were discussed on the current. So if you want to go back to the CBC podcast on the current and listen to that, there's 3 perspectives: a patient perspective, Dr. Howard Churkow, one of our national leaders and leader of the Canadian Collaboration of Neurodegeneration, and then another specialist from Britain. PET scans can also be done for tau amyloid, tau and amyloid, and so these are 4 separate people you can see there. In the top 4 frames, this is amyloid imaging. So the first 3 are 3 different people who are all cognitively normal. And you can see that the amyloid is increasing. So even though there's fairly extensive amyloid, that they are still cognitively normal, but then they have dementia by the 4th image. The same people looking at the tau imaging, you can see that the tau imaging is following along later on, and a person has cognitive impairment by the time they have that amyloid and tau, but particularly the tau affecting the medial part of the medial temporal lobes and the hippocampi in particular. For our blood tests, and I'm only going to mention one of them, there are several, but just to use this as an example, this is amyloid beta, measuring it in blood, A beta 42 to A beta 40, and this is measuring very low levels of these proteins in the blood, so requiring very special equipment to do this and methodologies. And this has been studied in people, normal controls, people with mild cognitive impairment, and people who have Alzheimer's disease. And a lower level of this ratio, so a low A beta 42 over 40, is found in individuals who have amyloid on a PET scan. So that correlates very closely. And the further study looking at this same sort of approach, measuring A beta 42 when combined with age and ApoE4 status, this can accurately predict who has amyloid accumulating in the brain without even having to do the PET scan. So amyloid beta 42 to 40 ratio could be used in prevention trial to screen people likely to have amyloid PET positive scans. So if that wasn't the case, you mightn't accept them or mightn't offer them to have a PET scan to be in the trial, because the PET scans are quite expensive. They're about they're about $5,000, and they're not available clinically. They're only available for research. In Canada, we have the Canadian Collaboration on Neurodegeneration. Dr. Churchill spoke today as the principal investigator for this initiative. Many dementia researchers across the country working on prevention, treatment, and quality of life themes. Through our own site in London, we have been the lead site for the Compass ND platform, helping the other 30 sites across the country to be able to help with this recruitment goal and various biomarkers there, including clinical questionnaires and all of the things, genetics, brain MRI scan, and optional lumbar puncture. And people can participate in this observational study. And we're getting close to the point where this, we anticipate, may close in the next few months. The Alzheimer's Disease Initiative is another study that we're participating in. And this is one where we're going to have continuing recruitment. It's going into a fourth phase of this ADNI study. And the focus of this fourth phase is to be able to recruit people from minority backgrounds and to continue the work on biomarkers, imaging biomarkers, blood and genetic biomarkers. At Parkwood, some of the global trials that are available at the moment are the Elector, a phase 2 study, and also the Janssen study, another phase 2 study, intravenous antibody. The Elector study is interesting in that it's targeting microglial cell clearance of amyloid. So that's the hypothesis under which this trial, the Janssen trial, is an intravenous antibody to remove tau protein, not amyloid, but tau protein. And these infusions every 4 weeks over 2 years. And then this is followed by an open label phase, the OLE, for people that are participating. So everyone that participates in the trial will then be able to have exposure to this medication as well. And then the AHEAD trial, phase 3 trial using the ESAIS compound, which also is quite a promising looking compound. Dr. Bangu, one of my colleagues, is going to be taking the lead on this trial at our site. And these are some of the reasons we talk to people about participating in research. The placebo effect is the positive response to being part of a study, thinking you may be on the treatment even though you are on the placebo, which is a well-recognized, real effect. Close medical monitoring during the study. Stimulation and interaction with another group of people is important. We can refer people to the community resources because we're following them along. And if they're not already accessing and going to the Alzheimer's Society or getting caregiver support or be involved with the day programs, we can make those referrals. And then there's the open label aspect that I mentioned. And then altruism is often the reason that many people will, they say, it may be my friend, my neighbor, it could be a relative that might benefit. And this is the most common reason I see people saying, this is why I want to participate in research. So in summary, family members provide the history and early observations on the change in memory, language, or mood, the repeated memory tests through the family physician or specialist to capture that progression, non-drug approaches to try and slow that progression or prevent progression from mild cognitive impairment to dementia. In terms of mild cognitive impairment, I should have said earlier, maybe about 10 to 15% of people with mild cognitive impairment per year will progress to dementia. That's 10 to 15% per year, but about 25% of people won't progress. And we don't fully understand why that may be the case. So this is where the research is actually going to be able to help sort out some of those things, particularly with the new areas of understanding with the biomarkers and the new treatments. Thank you very much. I just want to acknowledge my colleagues and our team at Parkwood Institute, some of whom you may have already met. So thank you, and I would be happy to take questions now. There are a couple of video conferences, Zoom meetings, one already started now and another one, an international one going on around Aducanumab, which I want to be able to get to a bit later, but what I'd like to do now is to try and answer some of the questions. Some of the ones that were submitted earlier on, I hope I have answered during the presentation, but if I haven't, please ask your question again. So I think Dina or Susan is going to be curating the questions.
Thank you, Dr. Borrie. Thank you so much, Dr. Borrie, for such an informative and helpful presentation. To our attendees, I'm sure you have lots of thoughts and questions after hearing Dr. Borrie. We have approximately about 8 minutes available for questions, so we'll do our best to answer them. Again, a reminder to please put them in a Q&A and watch for the questions that have already been asked and to upvote any questions that are similar. If you're listening to the webinar on your phone and you have a question, please feel free to email me or call me after the webinar, and I'll be sure to pass those along to Dr. Borrie after the presentation. So
we can go longer, Dina, I think, so just let's see where the questions go.
Okay, great. Thank you, Dr. Borrie. Okay, so the first question that we have here is, what is the recommended sleep position?
Okay.
It's a popular one.
Okay, that's interesting. Now, this comes from a 2014 study. Lying on the side was better than lying on the back was better than lying on the side, which was better than lying on the front. And these were studies looking at the drainage of patterns of drainage from the brain during the night while people sleep. Now, the other thing you need to know about this study, it was done on rats. So it depends on what you want to believe, but it was a very, very sophisticated study. But to the point, restorative sleep is important, and the position may be less important than actually having a long enough sleep, and that it is undisturbed sleep. But I think and so when we talk of restorative sleep, firstly, restorative, you have to wake up feeling refreshed, and also you want to try and minimize interruptions during the night, and it wants to be of sufficient duration. 7 hours is a common term, and a lot of older people say, well, I can't sleep 7 hours, I have to get up and pee, and that's what they tell us in the clinic. And we look at strategies to see around sleep hygiene, how they can actually maximize that sleep. I think it's better to try and get sleep at night rather than having naps. What some people do, get into the habit of napping during the day, and this destroys sleep. Alcohol is a very bad thing to be drinking because it disturbs sleep architecture. So some people say, well, I'll have a glass of wine before I go to bed and that will help me sleep. But it actually destroys the normal architecture of sleep. So it's important to try and avoid some of those things, watching white screens. There's a whole literature around sleep hygiene as well.
Thank you, Dr. Borrie. The next question, would you recommend the newly FDA-approved Aducanumab for the mild cognitive impairment?
Boy, what a loaded question that is. Would I recommend it? Well, firstly, it's not available in Canada, so I can't actually recommend it. I think one needs to look at the evidence, and the evidence wouldn't meet the usual criteria of 2 randomized controlled trials which have positive effects showing the same thing. So it doesn't meet that bar. I understand why the FDA have accelerated this. Part of the acceleration has been because of the expectation of being able to try and find a treatment, even a cure for dementia. Certainly, many people are seeking this. Patients are seeking it. Alzheimer's societies certainly want to see something to be able to direct people to help them. I think we have to be patient. I think this may be an advance, or it may not be, and I'm uncertain about this. Potentially, the cost of this drug would be huge, and if it was something that was not covered by the Ontario Drug Benefit Plan in Ontario or in other jurisdictions in Canada, if it's not covered, then only individuals who are able to access that type of funding are going to be able to access it, and that's going to exclude many people. However, could we actually get much bigger bang for the buck at a population level if we could use that funding to actually look at some of the strategies to actually prevent the disease or to try and slow the progression of the disease? Because people can obviously die of other things. People die of heart attacks and die of cancer. So if they have some mild cognitive impairment, people can still drive a car. They can still enjoy and engage with their grandchildren. If they've got severe dementia, that's obviously not a case. But if you can prevent that progression, that may be important. So I think we need to look not just for drugs for the answer. I think we do need to take seriously these multi-dimensional studies which look at multiple interventions. And there is going to be a Canadian study in the future, the CAN Thumbs Up study, which will be a multi-dimensional study trying to look at some of these different strategies that might do. But sometimes for people, it's easier to say, well, I'd rather take a drug than go out and exercise or necessarily eat a Mediterranean-style diet. That may be, particularly if someone else is paying for the drug. But right now, the cost of the drug is huge, and so I think that's a very big barrier. And we don't even know if Health Canada will approve this drug. I mean, I think I would like to see the result of that trial that the FDA has asked Biogen to complete, and I hope it's going to be able to be completed quickly to give us that answer. There are other compounds coming along as well, so we want to see how do they line up. So I think this sort of opens the door a little bit, but I think we have to be patient.
Thank you so much, Dr. Borrie, for that thorough answer. What is your advice if a GP does not have the time or interest to deal with an elder's onset of dementia? And when there is, so I just lost, the question just got lost. I'm not sure what happened.
I think I get the sense of it. So it's the time. So we have talked about the time. It does take much more time for a family physician. And certainly if going to a family physician, you've got to be able to have the time. It can't be done in a 5 or 10 minute appointment. It has to be booked as a counseling appointment, and it may have to be booked over a series of different appointments to be able to give the family physician sufficient time. If they don't have the time, they have their practice is structured that wouldn't allow the time, then I think there are other resources. Certainly people can be referred to the primary care collaborative memory clinics, which are now called MINT clinics in some family health teams. This is a phenomenon in Ontario that some people can access these MINT clinics to actually get assessments, and sometimes getting a referral to a specialist. The waiting list for someone to be seen in our clinic right now is about 10 months, so there is a wait. There are things that the family physician might be able to do that would be helpful, would be do a memory test. That would be give us a baseline memory test, and then we have something to compare later on. The Alzheimer's Society has in the past, or some Alzheimer's societies actually are involved with the family health teams. Some of them have had some of their staff involved with the primary care memory clinics, helping with some of those memory testing and some of the counseling of family. Certainly talking with people at the Alzheimer's Society, you can go to the Alzheimer's Society and seek advice there, because you don't have to have a diagnosis of Alzheimer's disease to talk to someone at the Alzheimer's Society and get some advice or some direction and get some literature. But certainly being informed is important. A lot of people who do that preparation ahead of time come with the diagnosis thinking, saying, look, I've done this reading, I think it may be a form of dementia, I think it may be Alzheimer's disease, what do you think? And they may be right on the money. Now, I'm not suggesting that people self-diagnose, but I think people can be proactive as well while they're waiting to get that assessment done.
Thank you. Can you talk about cognitive exercises?
Pardon?
Can you talk about cognitive exercises?
There is certainly literature around cognitive exercises and different types of exercises. In Canada, at the Baycrest, there is a group who, Nicole Anderson, is looking at different types of cognitive exercises and have been studying that and have published in that, and there is benefit in doing that. There's also Sylvie Belleville in Montreal who has been working together on that. And cognitive exercises, cognitive simulation will be part of the CAN Thumbs Up. I anticipate it will be one of the intervention arms. So I think there is a growing body of evidence around the balance of cognitive exercise. It's important to do something that's new and different, I think, as well. It's not just doing the same thing that you've always done. If you always like to do Sudoku or crosswords or word searches or something, it's actually extending the brain, because you've got billions of neurons in there, and what you're trying to do is to build in plasticity. And what that means is getting one neuron talking to another neuron that it never used to talk to, and keep doing that by stimulating the brain in different ways. So finding new and interesting ways to stimulate the brain, but it shouldn't be so stimulating or so difficult that it's actually frustrating. It shouldn't be frustrating the brain. So I think there's great value in that. So it's certainly something that we ask people to do, and people come up with some very imaginative ways to do that.
Thank you. Please outline the effect of NSAIDs on brain health.
And NSAID on brain health?
Yes.
And NSAID, okay. So these are non-steroidal anti-inflammatory drugs, and there is some evidence and certainly some thought that non-steroidal anti-inflammatory medications might be helpful on the hypothesis that part of Alzheimer's disease is an inflammatory process. So there have been clinical trials of non-steroidal anti-inflammatories in people with mild cognitive impairment and with Alzheimer's disease, and those have not found to be beneficial. So those trials to this point have not been of sufficient benefit to warrant someone saying, I'm going to take non-steroidal anti-inflammatories regularly to try and prevent Alzheimer's disease. Now, part of the other evidence around non-steroidal anti-inflammatories came from the observations of certain people, certain researchers, that in people who took non-steroidal anti-inflammatories for conditions like rheumatoid arthritis or other types of arthritis, that these people were less likely to develop dementia. That is an observation. It's not based on certainly any randomized controlled trial, which is the gold standard. And so when we take that observation in people who have arthritis and take non-steroidal anti-inflammatories, and that there may be a lower occurrence of cognitive impairment or progression to dementia in those people, it doesn't translate when you actually do the randomized controlled trial. So I think at this point, I don't think there's sufficient evidence to say that one should be taking non-steroidal anti-inflammatories if you don't have arthritis or some inflammatory condition.
Thank you. So Dr. Borrie, I'm just mindful of time. It's just over 7:30. It's 7:35.
We can go a wee bit longer if there's any other questions, if you need.
Yep, there are a few more. So I'll keep going. So the next one is, what are your thoughts on brain supplements, natural such as Retamide?
I would say, and certainly we have patients who come and ask these questions in the clinic, and I would say, can you help me understand what is the evidence that these things actually make a difference? Because if we're going to hold drugs like Aduhelm to a standard of successful clinical trials, I would say the same thing should be true of natural supplements as well. And a number of these natural supplements have been studied by the Alzheimer's Disease Cooperative Study. They have published those studies. They've looked at things like turmeric, for instance, ginkgo biloba. They've done these randomized control trials and not seen that they're effective. So these supplements are sold through various pharmacies or through health food stores or things like that with very flashy labels and claims that they are important for brain health, but the evidence just isn't there to support it. So I would think it'd be better to save the money on those supplements, maybe spend it on buying some, supplementing the diet and having omega-3 fatty acids through fish. It's better to have it through the fish than through the supplement as a fish oil capsule, because those have also been tested. And I think it's the complexity of diet that makes the difference. It's not just the fish, it's everything else that you're eating with the fish that helps with the diet, for instance. But I think for the supplements, I haven't seen the evidence. Now, if people feel and believe it makes them better, that is their choice, but I would ask them for the evidence.
Thank you. What are your thoughts about metformin as a treatment for Alzheimer's disease prevention?
So this is metformin.
Yes.
This is an interesting one, and one of those clinical trials on that diagram I showed is on metformin. So eventually we will get the answer to metformin. Metformin is a drug that's used in diabetes. It's an old drug, and it has the effect of reducing insulin and what it is felt that there's a hypothesis that maybe it's going to be beneficial to people with Alzheimer's disease. Again, I would say let the science determine what that answer is. And if people are really interested in it, if there's that clinical trial, I don't know if it's available, it's not available to us here in London, but I think that's a trial that one would want to watch, look at that evidence as it comes through and see, once you get to a phase 3 trial, if metformin in people in the treatment arm shows a slower progression of dementia, then that would be the proof of that. But I think you have to look at the evidence.
Thank you. The next question is, should the drug doxepin for insomnia be avoided for someone who had a parent with Alzheimer's disease? The dose is 10 milligrams nightly. And then it says anticholinergic.
Anticholinergic.
Thank
So,
you.
so this person's asked the question, is very well informed about doxepin. This was an antidepressant. It was one of the tricyclic antidepressants that was marketed in the early 1970s. So it's an old drug, but and it's effective as an antidepressant, but it is a strongly anticholinergic drug. And strongly anticholinergic drugs are the people who are on these for long periods of time, that is a contributing factor to dementia. It suppresses cholinergic activity in the brain. So other drugs like doxepin, amitriptyline is also used for sleep, imipramine, nortriptyline, sometimes used for various pain disorders. Gravol, I mentioned. Some of the older bladder medications, oxybutynin, which relaxes the bladder, but it also is an anticholinergic agent. So anything that has that anticholinergic should be avoided. So the answer would be for this, that this should not be used. The medication that we like better is trazodone, and it's a medication, it comes in a 50 milligram tablet, but you can take just a quarter of a tablet or half a tablet. So 12.5 or 25 milligrams may be sufficient to help with sleep. And then looking also more importantly at sleep hygiene, all of the things around that would also help to get a restorative sleep.
Thank you. So Dr. Borrie, again, I'm just very mindful of time and your other commitment. It's now 7:40. I'm thinking that we're going to just wrap things up right now so Dr. Borrie can go on to his next commitment. I want to, first of all, thank you again to RBC Wealth Management, Dominion Securities, for generously sponsoring this event. To Dr. Borrie, thank you so much for taking the time out of your busy schedule today to share your knowledge and your expertise with us. We know your presentation will stimulate further conversation. To our attendees, thank you so much for attending this month's Brain Matters, especially on such a lovely evening. It was a pleasure to have you all.
Thanks
So
very much.
so we will be taking a summer break from our Brain Matters webinar series, and we'll look forward to resuming these back in the fall. We would like to point out that our programs and services are free of charge to our clients, and donations to help support our mission are always appreciated. In closing, we would like to thank everyone who supported us for the IG Wealth Management Walk for Alzheimer's event this year. Together, we raised over $140,000. Amazing. These funds will continue to support families within our community going through the dementia journey. Lastly, please complete a short evaluation when you leave the webinar today. It should pop up on your way out when you click the little red leave button, or you can certainly take a picture with your phone with a little the IQ square, Q square on the screen. Thank you again for attending and enjoy the rest of this lovely evening. We'll see you soon.